Aloha, everyone. Happy New Year and happy Aloha Friday. Thank you for joining us today on the Hawaii Public Health Training Hui's webinar, The Good News About HIV. Before we get started, I just want to go over some Zoom housekeeping. My name is Makamai Namahoa. I'm with Hawaii Public Health Institute. And thank you all for joining. And so we're just going to get through the webinar, and then I'm going to hand it over to our speakers. So first, I want to thank the organizers for this training, Hawaii Public Health Institute, myself, the Hawaii Public Health Training Hui Steering Committee, which consists of 12 community partners here in Hawaii, and then the Pacific AETC Hawaii and a U.S. affiliated Pacific Island Center. I'll thank our sponsors for providing today's credits, the Hawaii Public Health Training Hui, the Western Region Public Health Training Center, as well as the Public Health Learning Network. For folks that are joining on, just want to let folks, everyone's muted upon entry. For any questions or comments that you folks have for the speakers, please utilize the chat box and the Q&A box located at the bottom of your screen. We'll be collecting questions and we'll be able to bring them up to the speakers at the end of their presentation. And that this meeting will be recorded and it will be shared on the Hawaii Public Health Training Hui's YouTube channel. And that link will be sent to you folks in the Mahalo email shortly after this training. Continuing education credits that have been provided for today. We have been approved for CHES, registered dietitians, licensed social workers, and licensed clinical social workers, as well as substance abuse counselors and prevention specialists. Oops. In order to obtain your CEs, you have to first register and attend the training. So congratulations, you're already halfway there. I will be emailing you folks a web link for the evaluation shortly after this training. Please please submit your responses by Wednesday, January 17th. So that way we can have you noted for earning CEs. Certificate of attendance will be emailed out to you folks by January 26th. And for folks that are calling in, please email me at makamai@hiphi.org with your name and phone number so I can make sure that you folks have receiving the Mahalo email. And before we get started, I want to introduce you to our speakers. Dr. Goshima is an internal medicine and HIV specialist who has over 4 decades of experience in treating people with HIV. A graduate of the John A. Burns School of Medicine, he began treating HIV/AIDS patients since the beginning of the pandemic in the early 1980s. He serves as the principal investigator of the AIDS Education and Training Center at the University of Hawaii. He helped physicians and nurses across the Pacific, including Samoa, the Federate States of Micronesia, Saipan, and Guam, to help treat patients living with HIV. He received the Suzanne Richmond Crum Award from the Hawaii State Department of Health in 2006 for his outstanding contributions in uplifting HIV care and prevention in Hawaii and the Pacific. Our next speaker that we'll be hearing from is Dr. Louis Mar Gonkwanko, who is an assistant professor of medicine at the Hawaii Center for AIDS at the John A. Burns School of Medicine at the University of Hawaii at Manoa. He is an HIV specialist certified by the American Academy of HIV Medicine and board certified by the American Board of Preventative Medicine. He trained in internal medicine at Yale New Haven Health, which is at the Bridgeport Hospital, and completed his residency in preventative medicine at Griffin Hospital, Yale School of Public Health. He served as an HIV research fellow at the Nagasaki University Institute of Tropical Medicine. He has 2 master's degrees, Master's of Science in Tropical Medicine from the University of Hawaii, and Master of Science in Clinical Trials from the London School of Hygiene and Tropical Medicine. He is currently an attending physician at the Clint Spencer Clinic at UH Clinics in Kaka'ako, providing HIV specialty and primary care services. So without further ado, I'd like to hand it over to our speakers.
Thank you very much, Maka. So, the good news about HIV. Okay, thanks, Louis. So, Amanda, you want to take care of some of this, or do you want me to do it?
Sure, I'll take care of it. So, at the Pacific AIDS Education and Training Center, the Hawaii and U.S. affiliated Pacific Islands, we offer all of our trainings for free. The only thing we ask in return is that you register for our sessions, because we're funded by HRSA, and that's how we show that we're actually out here doing our job. So our funding basically depends on our registration. So if you get a chance right now, and your phone can do this on the computer, go ahead and grab this QR code and register. If you've never registered for one of our sessions before, it takes a little bit of focus, but ever after that, it's very quick. So if it seems like they're asking a lot of questions, just answer what you can and realize you won't be asked those questions again. I will also be putting up the URL code and this explanation again in the chat a little way down the road for people who have attended late. So with that, I will turn it back over to Dr. Goshima.
Okay, thank you. This is our disclaimer from Pacific AIDS Education and Training Center regarding the fact that we are receiving funding from HRSA, and that we are assuring them that we are not that what we are presenting is our information that we would like to present, and that if we're using any trade name, we're going to, for medications, for example, we will disclose what they are. Thank you, Dr. Louis. Next slide. Okay, these are our learning objectives. One is to describe the evolution of HIV treatment and its impact on the surveillance expectancy of people with HIV. Second is to explain the HIV treatment as a prevention strategy, one of the good news of HIV. And the third one is to discuss pre-exposure prophylaxis. We're not talking about prophylaxis, we're talking about before exposure and its impact on HIV transmission, another good news. The next slide, thank you. HIV is a human immunodeficiency virus, and that is a virus that causes the acquired immune deficiency syndrome. It does attack the immune system, and it attacks this particular, so this is the virus. So it attacks the immune system. So the immune system is what helps fight off infection, cancers, and other things. So it's a very important system, and this virus attacks it. And that's why you will see a lot of manifestations of the effect of the virus by its effect on our body. So without treatment, people with HIV will develop AIDS. And treatment greatly delays disease progression and prevents HIV transmission. However, at this point, we do not have a cure for HIV. Okay, next slide, please. So as I mentioned before, it affects many different parts of the human body. And these are some of the more significant infections that you will see with someone who has untreated HIV and has developed AIDS. So you'll see infections of the eye, cytomegaloretinitis. You'll see infection of the brain, HIV-related encephalopathy. You will see infections of the lung, like pneumocystis jirovecii, pneumonia, Mycobacterium tuberculosis, not only the lungs, but extrapulmonary Mycobacterium. You'll see chronic intestinal cryptosporidiosis, and then also it can affect the reproductive system by having invasive cervical cancer. Some of this by way of effect on viruses, other viruses, and immune suppression. Next slide, please. So the good news about HIV. The first good news is we're able to detect it. So there is a test that can be done to detect whether someone has HIV, been infected by HIV. So it is recommended by the U.S. Public Health Task Force that clinicians screen for HIV testing in all pregnant persons, including those who present labor and delivery or whose HIV status is unknown. So it's imperative, and I think that most places do screen for HIV in pregnant women. The second thing is it also recommends that HIV testing be given to adults aged 15 to 65 years of age. The age group has been determined based on the the prevalence of HIV that's seen in the population. And so that's the group that they have chosen. And some people say, well, that's a little young for people, age 15. Well, pregnancy occurs. So what happens when how to get pregnant? Well, you have sex. So that's why. And that, we're the age of the seniors, we still can have sex at the age of 65. So, however, there are younger people that have sex and older people who have sex. So if they feel that they are at risk, they should also be screened. And this is a grade A recommendation. It's really strongly recommended that this testing be done in these groups of patients. Next slide, scene, please. Okay, so this is what has happened in general about HIV over the years. As you can see, there was a horrible period of time when HIV increased and increased. And in the 1980s, that is when the peak of the epidemic was. Actually, that is sort of in the 90s, but when I was practicing medicine, it was in the 80s, and that's when we started to see that rise in that. But it was a terrible, horrible period of time. But as you can see, it has decreased. Death has significantly decreased, and the amount of HIV seen has decreased. And that's in part due to the availability of highly active antiretroviral therapy, or HAART, HAART. And it's been available since 1996. Next slide, please. And what is taking HAART has on mortality? As you can see, as the number of persons, patients took ART, you can see a significant drop in deaths over time because of taking antiretroviral therapy. So this is one of the significant good news of HIV, is that medications, once diagnosing it, two, if you take medications do work and prevent death. Next slide, please. So this is what you can see now over the many years that we have been treating HIV. Although, unfortunately, there is no cure, the HIV is no longer a death sentence. So medications help people with HIV live longer. And you can just look at the bar graphs there. Person without HIV, their lifespan may be up to 79 years. And people with HIV, they can live up to 71 years. So it's almost equivalent to a normal lifespan for a patient. And however, if you do not take medication and not being treated for HIV, you can have significant decline in your years of life. So in fact, remember, infection is lifelong. We do not have a cure. However, it is treatable. And you can see that it's almost like a cure, that you can live a full life, even if you have HIV infection. That's one of the other good news about HIV. So how do we determine how we're doing as a state in treating this epidemic? So we do it by looking at how we take care of our patients. And by this, we call the HIV treatment continuum. And all the states have this. We are judged by how we are looking at the number of HIV cases, how many are diagnosed, how many of them are then brought into care, and when they receive care, whether it's right away or they get it later on. And not only getting into care, but staying in care. Remember, this is a lifelong treatment. So staying in care is really important. So that retention of care is very key. And of course, the overall goal is to get viral suppression, because by suppressing viral load, you can suppress the virus and viral infections effect on the body. And you'll find out later on how this can also prevent transmission of the virus to other people. So this is how we measure how we're doing in response. And you can see that Hawaii has really improved from 2011 to 2018, and there are newer numbers to suggest its continued improvement. So we are looking at very high uptake of treatment to treat HIV patients, and in the long run, increase the number of patients who have undetectable viral load, so they're being suppressed. And remember this term, viral suppression. It's key to determining a number of different other good news things. Okay, next slide, please. So again, here you can see it in the year 2020. We are in really high numbers of that. So, our linkage to care is high, as well as receipt of any care, and then viral suppression is in the 80s. And these are some of the goals that nationwide and worldwide are some of these numbers percentages that they're looking for us to see how we are doing as far as controlling HIV infection. Next slide, please. So any questions, as we said, please put in the chat. I tend to talk a little bit fast. Yeah, just do that. So this is Hawaii specific diagnosis between 1983 and 2021. You can actually see, and Hawaii is a little different in that they measure the total number of HIV cases that they've had since 1983. Okay, so they add that on there. So we do not have a lot of infections. We had 4,341, but you can see that a lot of them are in stage 3 AIDS. So that's a little concerning, meaning that a lot of them are presenting late in HIV infection. They're not coming in just because, I wanted to get tested or something like that. No, they're coming in because they're having symptoms. And stage 3 means they already have AIDS. So they're coming in one of those infections that I showed you at the beginning of the talk, encephalopathy, pneumonia, things like that. They're presenting that way. And we don't want them to present that way. We want them to come in as early as possible. The majority of cases are in the Honolulu County area, but these are some of the things that are happening. We're tracing them. And the good thing about Hawaii and the State Department of Health is they're really good with contact tracing and trying to get the patients not only diagnosed, but into care as well. So we're working very hard in Hawaii to get our continuum of care improved. Next slide, please. Okay, some of the other good news is therapy. So treatment simplification is another good news. So, therapy was designed to interfere with various parts of the viral life cycle. And we found out early on that a single medication was inadequate to control the virus. So then we used what they call sequential. We tried one medication, and the medication stopped working. We go to the other one, and that really quickly moved through all the medications that we had. And therefore, with some basis in other treatment of other diseases like tuberculosis, where you needed more than one medication given at the time to control these infections, that combination therapy was used and proved to be effective. So now these newer medications, this treatment has not stood still. They are now stronger, more potent, newer, less toxic medication became available. When I was starting and we first had medications available, a patient would take literally a handful of medications per day. Some medications, 18 capsules in one day. And we're not talking like a small little capsule. We're talking about what looked like a suppository. It was that large, and people would take them, but they were not that effective. They were helpful, but newer medications are available, less toxic. Now, in the era of multi-drug single tablet regimen, you will see multi-drugs in one tablet, one capsule, that will take care of a 3-drug regimen. It is truly amazing. Not only amazing in that they can do it, but it involved working among the various pharmaceutical companies, because they were not all made by the same pharmaceutical company. And they would have to work together to make a combination medication to be used. So that is truly amazing too, that this cooperation occurred and that they were able to get medications like that. And the latest bullet you'll see, cabotegravir rilpivirine, injected intramuscularly every 2 months now. They don't even have to take it orally. They can just get a shot every 2 months as a regimen. Well, actually, it's one shot in each buttock, but it's every 2 months. So they don't have to be reminded every day to take their medicine. They just get a shot. Okay, next slide, please. So this is the viral life cycle and targets in which we use to treat. So this is the virus entering the cell. It fuses with the cell, releases all its material into the cell, and some of it stays in the cytoplasm, which is that sort of orange-brown area, and others get into the nucleus, which is the blue area. And this is how the virus becomes part of the cell genetic material. So integration is the key thing. And so this is why we cannot get rid of HIV, because the viral DNA, RNA it's in the gene of the person who is infected. And once they're stuck in there, can't get them out. So far, this is what we know. But along that life cycle, there are various places that medications can work to block the production of the virus. And that is the main goal, is to keep the virus under control, so that it doesn't spread to other people. Next slide, please, Louis. Okay, so what is antiretroviral therapy? Well, it does definitely work. It reduces the amount of HIV in the body, reduces the risk of HIV transmission. This is another good news. It prevents HIV from advancing and protects the immune system. So I'm going to go with that second bullet there. If someone takes medications on a regular basis, we're talking regularly, not just when they feel like it, they have found that by getting the virus to an undetectable viral load, you can actually do two things. One is you can prevent the spread of HIV to another person. And two, if you get it to undetectable, your immune system will be protected because the virus is under control. Next slide, Louis. So these are examples of 1 pill once a day antiretroviral therapy. Again, this is amazing. 3 medications in 1 pill. And look at them. There are on this page, there's 4 of them. On the next page, you'll see that these are medications that have only 2 medications. Well, one at the top, the dolutegravir only has 2 medications in it, and the one on the bottom has 3, but it has a booster in there. But on the side, you can see long-acting injectables. So this is the one we were talking about, that people can now get a full antiretroviral regimen every 2 months with a shot. They don't have to take pills every day. They can just get a shot, 1 in each buttock, every 2 months. And they're thinking of extending it out longer. They're doing some studies on that. Okay, next slide, please. So this is what antiretroviral therapy means. we are trying to reduce the viral load as much as possible for as long as possible. So you can see with the visual viral loads before ART, taking medication, and the viral load with ART. So the detectable level drops to undetectable levels. And what does that do? It increases, well, it keeps the virus under control, but it increases the CD4 cell count because the virus is not killing off these cells anymore. And ensures medication adherence to preserve ART options. So the good thing is that you saw the number of different medications. There's a possibility that unfortunately, if you can't take one, for whatever reason, you become resistant to it, or you have side effects or something, there are other options that you might be able to do to continue on having a very simplified regimen that will keep you adherent to keep that virus under control. So it does preserve the quality of life, because many of these medicines are very potent, single tablet, taken only once a day, and they have very little side effect. They're very potent. So that's great. But the added benefit is they can reduce HIV transmission to another person. So U equals U, undetectable equals untransmittable. So this is part of the thing of, treatment as prevention is a new thing. You never thought that a person who has HIV has control over spreading HIV to others by, if they took their medication, they cannot spread it to another person. So it's important that our patients who have HIV, 1, get diagnosed with a blood test, 2, get onto treatment, 3, stay onto treatment, take the medicine so they have an undetectable viral load. And because of doing that, they can prevent the spread of HIV to another person. And it is very, very important. I think that statement is quite good because it puts it the strength of your body and the control of how you can do something, make a conscious effort to be able to control this infection. Yes, it would be nice just to get a shot and make it go away, but if not, human will. You can do it by having that resolve to not spread HIV to another person. Okay, next slide, please. So some of the good news also has been regarding some of the things of prevention therapy. And the first one that became available a long time ago was the prevention of perinatal HIV transmission from an infected mother to a child. They did try medications to give mothers who had been infected by HIV medication, antiretroviral therapy. Most effective was taking it prior to delivery, but even in delivery, so intrapartum, they could be given medication that would significantly reduce the impact of transmitting HIV to their baby. So, and then continuing those medications after the baby was born. So there was significant drops in HIV perinatal transmission, so much to the point that our pediatric HIV clinics are no longer in existence because there is none if they follow this. So again, this is a graphic of what happens. This is what you can do, where you can impact the spread of HIV in pregnancy, labor and delivery, pregnancy, taking medications prior to delivery, labor and delivery, when you're delivering, because there's a lot of blood involved, and in delivery, trying to prevent that from occurring, and breastfeeding. We know that breastfeeding can spread HIV through the milk. So those are ways you can do it. And you can see the effect of this, the significant decline in perinatal, the number of, children being really significantly dropped because of the significant perinatal regimens that have been done. So this works. And this was, you can see, very early. I mean, this is 1990s. They started using this. So this was our first indication that something can be done to prevent HIV, at least in one setting, a significant setting. Next slide. Okay.
All right.
I'm going to hand it over to my colleague, Dr. Louis Gangwanko.
Thank you so much, Dr. Gashima, for that. I think at this juncture we can entertain some questions before we move on to our next
Yes.
topic. Miss Amanda, I don't seem to see the chat, so if you want to read, if there are questions, or
I don't see any questions.
are there any, feel free to just speak and ask questions, and you can interrupt me anytime too. So I'll just keep on going.
So
I
Anita,
think,
sorry, Dr. Louis, Anita
yeah,
asked, are the effectiveness of the shot the same as the pill?
yes, they are. They're equivalent. The shots are as effective as the pill, and it's every 2 months. There's recent data though that says that every year there's about a 1% failure every year, at least for the ones that they have checked before for cabotegravir rilpivirine. But they think that that is still kind of similar to what the failure rates for oral pills as well. So yeah, to answer your question, yes, everyone still gets suppressed within the similar a similar time frame. And we have quite a few people on this injectable here on Oahu. Yeah. Any other, yeah, and just to share, I had a patient who walked in one time and said, I've been on pills since the 90s. If you don't give me the shot, I'm not gonna take anything. You give me the shot, or I'll just be viremic. I don't care. And so we switch him to the shots, and he's now undetectable around in the hundreds. So we're having a little bit of a conversation that we may have to intensify his regimen to fully suppress him. So
We
any
do
other?
yeah, we do have another question. Do patients have any problems paying for their HIV medications?
No. Dr. Gashima, you want to answer?
Yes, there is, they are expensive. There's no question about it, but all insurances do cover all medications for HIV. I think that we have a safety net
Yes.
called HDAP. It's provided by the state, in which people who don't qualify for whatever reason can get medications free from the state.
Yep.
And so therefore there shouldn't be a problem with getting medication, including these more recent one, like the cabotegravir, rilpivirine shots. They can get them as well. So there shouldn't be a problem with getting medications. And I think that point that Dr. Louis' patient had is, we can't imagine someone who was taking medication all this time, going from the full handful of medication to just one, but still, I mean, one or two medicines, but still every day that patient is reminded that they have HIV. Every day they have to take that pill. They say, if I don't take it, I'm going to die. But every 2 months, they don't have to, if I miss it, I don't have to worry about that, because, I was having to regiment my life. So we don't realize the impact of someone who's taken, I have patients 30 years or more who are taking medications daily. And it's a lot. So one of the things they all mention is, you know, I take that pill every day and it reminds me, guess what? I have HIV.
Yeah.
So it's important.
It's pill fatigue, and it's also kind of the re-traumatizing, as Dr. Gushima said. It reminds me of that day when I got diagnosed, and it changed my life. But for the most part, other people are also just very happy that, hey, I had one patient who was on like 3 4 pills, and I saw him and I'm like, we could consolidate this into one pill once a day. And he couldn't believe it. And he wouldn't believe me. I said, I promise you this is going to work. And so we
Uh,
switched him to one pill. And I said, for your own peace of mind, for my own peace of mind too, we will recheck your viral load within 4 weeks. And it was undetectable. So, and he's still undetectable. And he's very happy that he doesn't have to take 4 or 5 pills a day, and it's just one. So, Miss
Yeah,
Amanda, is
so
there
yeah,
more?
so Ke Aloha from H3RC said about HDAP. HDAP can cover in Hawaii can cover medications fully or cover copays. There is also H Cobra, which covers insurance premiums to help those who don't qualify for MedQuest and don't have access to an employer provided plan. The aid services organizations can connect people with that. And I know there are a number of people from other states on this Zoom. And I believe that there is something similar to, there's a DAP program in every state. So the best way to find out about it is to go to hiv.gov.
Mm-hmm.
And then there's some other questions. Um, Oh, let's see. It looks like Viviana, it looks like you didn't oh, yeah, thanks, Keiko. It's ADAP. Okay. Um it looks like Viviana, you didn't finish your question. So I've always wondered if a person is HIV positive and adhering to treatment, and if you care to at some point, oh, wait, you did it below. Okay, so if a person is HIV positive and adhering to treatment, undetectable loads, can they donate organs?
Hmm. I don't think that they are allowed. I could be wrong, and let me tell you why. So HIV undetectable means HIV RNA in the blood is not detected in the assay. But let's remember that HIV actually integrates in the DNA and also infects other cells, not just the T cells. So that organ that you harvest, like a liver, it has hepatocytes, macrophages that can contain HIV. I think the answer is no, because now the liver that has the other cells that have HIV integrated in them could be transferred to the patient. Correct me if
We
I'm wrong,
we we
Dr.
have
Gushima.
we have somebody who works in
And transplanting?
organ donation.
Oh, great.
So
Perfect.
Melissa Lux, she says, I work in organ donation. You can donate if HIV positive.
An actual organ. Or every, across the board, kidney, liver. Okay. Huh.
So I guess the thing would be
Let's
is
see.
to check it out with,
Let me
yeah, she
check.
says any organ.
Huh.
So I think actually maybe we need to do our homework and find out from
Yeah.
our organ donation organization here more about that. Oh, okay. So she says it would only go to HIV positive recipients.
Oh, there it is. Okay, so
Okay, okay,
as
got
a
it.
okay, got, because there I'm just looking at it right now. There's the HIV Organ Policy Equity Hope Act, November 2013 by President Obama. Thank you so much. And these questions really clearly it stimulates our minds, right? And
Yeah.
we don't know everything, and we learn something new every day. And thank you so much for sharing that. Yeah, thank you so much.
And then Phil Russell has a question. He asks, is poor adherence the only factor that contributes to treatment failure or resistance?
Dr. Gashima?
Um, um, well, if you if they were sensitive for, if they were, if the virus was sensitive to the medication that they were taking or put on, yes, that is probably the most common and the reason why you would become resistant to the medication. Because if the virus, remember, the virus has to grow to get resistance. So if the virus is suppressed, you can't get resistance because it's in the process of them making another genetic material. It's where the error occurs in the HIV virus. So they have to be actively making genetic material that will mutate, that will, because they're selected by the medications that they're taking, that says, okay, you can't be resistant to this one, but if your levels are low and you can, it doesn't suppress the other ones, then you can get resistance to that one. So that's
So,
why go ahead.
oh, I was gonna add to Dr. Gushima, there are two types of resistance. There's acquired and there's transmitted. So what that means is, you're a person without HIV and you have sex with someone with a multi-drug resistant virus and they're detectable, you can get it and you get a resistant virus to begin with. And this is why when you start treatment, it's recommended that if you're able to actually check the resistance testing, this is drug susceptibility testing of that virus, that would be very helpful so that you know what it will guide what medications you're going to put your patient on. But that being said, majority of the HIV that we see are pan sensitive, meaning the drugs that we're going to give are going to be okay. And to answer your question, yes, absolutely. If a person stops, that's when you start getting resistance. Is inconsistent use. You let the blood level of your uh, antiviral drop and then it goes up. So you are stimulating the virus and giving it a chance to actually become resistant to it. So yes, the for the most part, that's the explanation.
Um,
Anything else, or should I
yeah,
carry
no,
on?
there's one more
One more,
that I
and then we'll
see.
continue.
If someone becomes undetectable, is it still possible to go back to detectable if they do not adhere to treatment?
Oh, yes.
Absolutely. Absolutely. In fact, unfortunately, we don't have that slide where, literally within 2 weeks or to a month, you will become detectable. So, because it comes out of its hiding place, you let the virus replicate, it will come back out, unfortunately.
Okay, great.
Yeah,
Right. So,
you
There are
just have to remember that the treatment, it doesn't get rid of the virus. That's why we cannot
mm,
cure HIV. All it does is suppress the virus.
we'll go back here. Yeah. This is it. You have a few more here, and then if you stop the treatment, unfortunately, it will go back up like that. It
Yeah.
will replicate. All right, we'll have a few more minutes after this topic. Okay. All right. So I'm Dr. Louis Maragong Kwangko again. Thank you so much for having me here. So one of the good news about HIV is we have PrEP. And what PrEP means is pre-exposure. For people without HIV, before they get exposed, they can take medications to protect them from HIV. So let's talk about what PrEP is. So PrEP is an HIV prevention method in which people who do not have HIV take HIV medication daily to reduce the risk of getting HIV. This is the official, I believe, CDC statement, but there are exemptions to this. I'm going to talk to you more about it because there's an injectable version every 2 months. There's also an on-demand version, but for the most part, this is the general concept of it. You don't have HIV, you feel that you're at risk for it, then there are medications for you. So, who are the people who are recommended, who are deemed at risk for HIV and may take PrEP? So, who have anal or vaginal sex in the past 6 months, and they have a partner with HIV whose status is unknown or detectable viral load, right? Or a partner with has an unknown status or detectable viral load, because again, U equals U, right? Have not consistently used a condom or diagnosed with sexually transmitted disease in the past 6 months. All right, or people who inject drugs, right? Because HIV can be transmitted through blood, and if you inject drugs, sharing needles, for example, sharing syringes, drug equipment with other people, that is really a high risk for HIV transmission. And obviously, the question is, what about if I'm pregnant or breastfeeding? The answer is yes. For the most part, we can give PrEP for people who are breastfeeding or pregnant, especially the oldest one, which is emtricitabine TDF, also known as Truvada. That one has the most data for cisgender women and people who considering getting pregnant. Okay. So how effective is PrEP? So PrEP is very, very effective. It reduces the risk by 99%, right? So especially when taken as prescribed, and by taken as prescribed, taken daily. So this is from sexual transmission. You decrease the risk of HIV acquisition from sex by 99%. As we have talked about, injecting drugs is a little bit of a riskier um, activity, and PrEP pills seem to reduce HIV transmission by 74% among people who inject drugs. The injectable PrEP shots, there's an injectable PrEP, not recommended for people who inject drugs. And again, PrEP is less effective when not taken as prescribed. And the way it's prescribed for the oral one, it's every day. For the injectable one, it's every 2 months. All right, so we're gonna talk about the injectable one, okay? Uh, oh, sorry. So, I didn't realize that I thought it was a 1 hour talk, so I removed some of the other slides. But suffice to say, there are three types of PrEP. There's the Truvada, which is the oldest one. Descovy, which is kind of a second generation Truvada. It is supposed to have a better safety profile for kidney and bone, because the older the tenofovir, called tenofovir disoproxil fumarate (TDF), has some kidney side effects if you take it for a long time, as well as low bone. It can decrease your bone mineral density, so it's not recommended for people with osteoporosis or who are at risk for bone mineral density loss. So the SCOVY, the second generation, is more preferred, but the population there, it's not for cisgender women, the SCOVY. And then the injectable is pretty much for both men, women, transgender, cisgender. Um, but it's not. There's no information on people who inject drugs. So clinically, um, there are three types of PrEP, and depending on your patient population, the good news is, there's always one for everyone. Another thing that I wanted to talk about is PrEP can also be on demand. There is what you call an event driven PrEP. It's 2-1-1. What that is you take two pills 2 hours before sex, one pill the day after, so 24 hours, and another pill a day after that. That's why it's 2-1-1. So if some patients say, I don't have an ongoing risk, it's just that sometimes, I will have an exposure. And so if they say, oh, I only think I need it once a month, 2 times a month, then they could potentially do 2-1-1. But again, it's not as effective as the 99% that's been shown in the oral uh, pills. The intravaginal ring. In Europe and Africa, for women, there is what you call a dapivirine ring, where it's women put it in their vaginal area, and it's replaced every 28 days. It releases an antiviral called dapivirine. Unfortunately, it's not available in the U.S. because, quite frankly, the risk the efficacy is way less than the PrEP that we know of, the Descovy, Truvada, or the injectable. All right, so I'm gonna just move on and then finish up with the post exposure and then the potential cures, and then I'll entertain questions. So post-exposure prophylaxis is what you call what post-exposure means after exposure. So this is like there are two types of post-exposure prophylaxis. There's occupational exposure, meaning, oh, I'm a nurse and I was drawing someone's blood and then had a needle stick injury. And the good news is that there are medications that you can take to prevent HIV transmission as long as you take it within 72 hours of exposure. Um, that's one type, right? The occupational. There's also the non-occupational exposure, meaning, oh, the condom broke. Therefore, I need to go to the emergency department to get PEP. So I'm putting it out there to let everyone know that in case something happens to you, uh, there is a recourse and it's highly effective. Again, the condom broke, it's an accident, or victims of sexual assault, we have seen them. Unfortunately, we will follow them through and they will be given antiretrovirals for 28 days. So it's a short course. So immediately after the potential exposure, you're given a combination antiretroviral and it's a 28-day course, and we will recheck the HIV tests, making sure that the person didn't seroconvert or did not get infected. And for the most part, it's very effective at preventing transmission. So this one is just showing that, be careful with the sharps, follow the general precautions. And these are the average risk. Actually, it's not very even if it's a percutaneous exposure, it's not really very high. But again, even if it's not high, it's 0.3%, for example, you still kind of want to make sure that you don't get HIV, right? So we've talked about this. If you get exposed, the condom broke, you got a needle stick, and obviously you assess the other patient too, because if you got a needle stick injury, the first question is, what is the HIV status of the source patient? If the source patient is known to be HIV negative, there's really no reason for PEP. Some people still demand it. I have been um, during my residency, there's a surgeon who was operating on a person with HIV and he cut himself during the operation. So he went to our occupational health clinic and we started prep on this PEP rather on the surgeon, and it's again it's just 28 days, right? These are the regimen. We're not gonna go to the nitty gritty of them. Suffice to say, it's a combination of three medications, and there are various medications there, like integrase inhibitor based three drug therapy. Um, and again, remember HIV is not the only thing you can get from needle stick or from these sites of exposure. You also need to check for hepatitis B virus and hepatitis C virus, right? So those are the things that you also need to bear in mind. And for women, if they
Hey,
are
Julie,
offered
this is Amanda.
emergency contraception, and will have Miss Amanda mute herself. Thank you. All right. Okay, so this is the risk assessment. You have to check, is it a substantial risk or negligible risk? Obviously, if it's a negligible risk, NPEP is not recommended. And what is the definition of negligible risk? If the contact is urine, nasal secretion, saliva, sweat, tears, those are not uh, substantial risk. You cannot get HIV from someone's urine. You don't get it from kissing. You don't get it from sweat. You don't get it from hugging someone. You don't get it from sharing food. So if that's the exposure that a person reports, there's no need for uh, post-exposure prophylaxis because those are negligible risk. But as this says, obviously, if there's visible blood, you may want to reconsider. And again, if it's intact skin, the blood was on your intact skin, that's probably not necessarily a substantial risk, but it's all there are gray zones like that where it's shared decision making, and for the most part, from my experience, the patient would want to have the post exposure prophylaxis anyway. All right, so let's move on. We've talked about this. NPEP, again, it's in the setting of sexual contact, not in an occupational work setting, and it's essentially the same. And the only added thing here, because it's sexual transmission, is potential for pregnancy and screening for other STDs and giving them prophylaxis for for other bacterial sexually transmitted infections. All right. Okay. Before we move on to potential cure, are there any questions in PrEP or PEP? I would have to potentially because I couldn't see the chat box. If you could yell it out.
Yeah. Yeah, here, doc, one person
Oh,
jumped on and said, "Do you have any recommendations for getting post-exposure prophylaxis, excuse me, in areas where providers may not be educated about it, like such as rural communities?"
I see. Well, you know, to be honest with you, majority are in the emergency department. But one of the things that can be done is, I know there's a national clinician consultation center where people could call that national consultation center for HIV, and the physician could will be advised and patched to an HIV specialist. So that's one way. And for the most part, to be honest with you, an emergency department or urgent care people normally would have an idea on what to do for that. But hopefully that answers the question. There's a national clinician consultation center. Miss Amanda, do you remember what the national clinician consultation center line is for HIV
I
consultations?
I will look it up and put it in the
Put in
chat.
the chat, right? We'll put it in the chat because then people could call that those the numbers. Thank you so much. Any other question or?
Yeah, one more question popped up. How long does a how long does a person need to be on Prep Med for it to be at least 99% effective?
That is such a good question, and I wish I placed that slide here. But to answer your question, if it's so taking it every day, if it's anal sex, 1 week. If it is vaginal sex, and again, it's kind of unfair for the women, right? Apparently, it takes 21 to 28 days. And the belief there is, because I see Maka's face like, oh, that's so unfair. Because I think it's really the drug levels, the prep penetrating the vaginal mucosa as well as the rectal mucosa. And this is just what the studies have shown. So 1 week for anal intercourse, 20 21 to 28 days, somewhere there for vaginal. But again, remember 2-1-1, right? You can take 2 pills 2 hours before sex, and that is still kind of acceptable. But again, the efficacy of that is only 86%, 87%, as opposed to 99% if you actually took it every day.
Awesome.
Hopefully that answered the
I
question.
think I
Any
think
other?
that did. No, none have
That
popped up. So folks, if
okay?
as the doctor's still presenting, please feel free to drop in your questions and
Yeah.
we'll chime in. So yeah, feel free to continue, doctor.
All right, so this one is, believe me, this is one of the controversial slides that we got feedback from our regional office before I was able to present this. So hang on here. I'm not sure if people are aware that there are actually people who have been born lucky to be resistant to HIV. Very, very small percent. Majority are of Scandinavian descent. They have this what you call Delta 32 mutation. Delta 32 mutation, and you have to be homozygous, meaning both alleles should be mutated. If you're only heterozygous, meaning you have both resistant and non-resistant, you could still be infected. So let's talk about what Delta 32 mutation is. So remember the slide that shows HIV docking in the cell and trying to invade the cell? For that to happen, HIV needs this receptor. This is your cell. This is the normal. This is a normal cell, T cell, and you have this CCR5. So a person without this mutation, and probably this all of us in this call, or a majority of us, our cells will express this. All right. And so that one, because HIV could bind to it, now the HIV could invade your cell. All right. So people have kind of a mixed, uh, they have the wild type and the Delta 32 mutation. So only half are mutated. They have less amount of that. And so to some extent, though they can still be infected with HIV, but they could be able to control the virus to some extent. But now the most intriguing ones are those who have been born with this mutation, where they absolutely have no CCR5 receptor on the surface. And what that means is HIV enters the bloodstream. It tries to look for the cells to infect. It finds the cell, but it's like lock and key. It doesn't have it cannot enter it. So people who have this are protected against HIV. And again, that's I think, if I remember off the top of my head, about less than 1% of the Scandinavian population has this mutation. But as a corollary to this, though, it's found that West Nile virus, they're kind of at increased risk of West Nile virus. So that's just as a side that, although it protects you from HIV, there are other viruses now that you're a little bit susceptible for. So I had the pleasure to actually meet people who have achieved HIV remission or functional cure after stem cell transplantation. So what that means is, so this is the Berlin patient, Timothy Brown. Unfortunately, he passed away a couple of years ago. And these are the three patients also who were had functional cure after stem cell transplant. So what happened to them is they have blood cancer, and because they needed to have stem cell transplantation, their donor, they were transplanted with the stem cell of a person who has the Delta 32 mutation. So now their bone marrow produce cells that are resistant to HIV. So they have blood cancer, but they have the wild type, right? They have the normal amount CCR5. Their donors, now they look for a matching donor that had the mutation, and now their blood has been replaced with the donor that now doesn't have the receptors, and they cleared the virus. So this is Mark Franke, the Dusseldorf patient, Adam Casillejo, the London patient, and Paul Edmonds from Southern California, the City of Hope patient. And they were all here during the Hawaii to Zero conference recently. So it is very promising. But again, stem cell transplantation is not for everyone, because there's about 40% mortality with stem cell transplantation. You have to immunosuppress the patient. I think Timothy Brown and all of Paul Edmonds, I believe, or was it Mark Franke, they actually got very, very sick from the procedure because their body was trying to reject the stem cell. One other thing that is not included here is scientists are trying to use CRISPR or gene therapy to edit out that. Remember, you see that slide that HIV integrates. They're trying to get it out of the cells as well, or trying to induce a Delta 32 mutation without doing transplant. So those are some of the things that are being investigated for HIV cure. So hopefully that is kind of one of the good news, is that people are still actively searching for a cure. Although it's very challenging because HIV mutates. There are several subtypes of it, and it's just almost like a moving target. So In summary, advances in HIV antiretroviral therapy has allowed for people with HIV to have life expectancy close to that or similar to that of HIV seronegative individuals. One of the key concepts that we talked about is undetectable, is untransmittable. Because of advances in HIV treatment, people can now live long lives with undetectable viral load using, for the most part, one pill once a day or an injectable every 2 months. So people with HIV who take antiretrovirals consistently and achieve undetectable viral load do not transmit HIV to their sexual partners. Again, the key word here is sexual, okay? Because remember, we talked about injecting drugs. U equals U doesn't apply to use of injecting drugs. And then daily pills called PrEP are highly effective in preventing HIV acquisition. And now we also have uh, the injectable PrEP, and I just spoke with some of the pharma companies. They are now investigating a once a month oral PrEP. So that's in the pipeline. Can you imagine just take it one pill once a month, and that should hopefully protect you. But again, that's in the horizon. But we don't know how that's gonna turn out. So thank you so much. This is Dr. Gushima's email. Unfortunately, I think he has an unstable internet connection. So, um, if you have questions directed to him, this is his email. This is my email, louismag@hawaii.edu, and I'd be happy to answer questions. And yeah,
Awesome. Thank you. Thank you. Thank you both. I know we lost Dr. Kushima a little bit earlier, but I just want to echo, I think his presentation was so informative and we got a lot of questions coming in. So I think that speaks
I
true to
know.
the interest that folks have in this topic and the reliability here. We had a question kind of pop up before at the end.
Yeah,
So would it be possible to save stem cell blood would it be possible to
stem
save
cell cord.
stem cell blood cord cell cord blood at birth and cure yourself of HIV later in life? Ooh, great question.
That is a very intriguing question. Huh. That's not a bad idea. I mean, I would say that I just don't know how long can you save bl- your stem cells. I would say that it's not an impossibility because you are just giving it back to yourself. But you see, but that's on the assumption that you have the mutation. But if you don't have the mutation, you're giving yourself stem cells that will also be infected with HIV. So actually the answer is no. Because if you are the wild type that has the receptor, that saved cord blood would still produce cells that will still be infected by HIV. It has your donor needs to be someone who is resistant. And Miss Amanda owes me a drink after this because I'm putting the registration up, okay? Sorry, please help us. HRSA is kind of on us, trying to count every single person who shows up. Uh, Please, any other question I'd love to answer
Awesome. Thank you
here.
for that. We had another question come in. Somebody had made an anecdote. I have had a client ask that engage in oral sex, but no exchange of bodily fluids. Would they still be at risk?
I have to tell you, this comes up all the time. The theoretical risk for oral sex is less than 0.01%. So even people who are like, oh, I just do oral sex, I don't do anal sex. Do I need PrEP? And is it a significant risk? I have to tell you, actually, over on record, yeah. But from experience, I mean, the official answer is the risk is less than 0.01%. How you, the value of that 0.01 for a patient, is that big enough or small enough? Clinically, I would say I would not recommend PrEP or PEP for that person. Unless your gums are bleeding, you have open wound and sores in your mouth, and that could be a portal for the virus. Just plain oral sex without actual ejaculation, I think it's falls within the less than 0.01%. So it is still a low risk.
Okay, we just had one more come in. Do patients have to be undetectable before they can start on injectable ARTs?
All right, very, very, very good question. And this is a trick question because the FDA pamphlet, everything is all about guidelines, right? And FDA, if you go to Cabenuva, the answer is yes. It's only FDA indicated for people who are virologically suppressed. So it is an incentive for your patient to say, hey, look, please hang in there. Just take your pills. 2, 3 more months, you're gonna be undetectable. Then we will convert you to the injectable, right? But have people done it because their patients have threatened them that if you don't give me the injectable today, I'm not gonna take anything? Absolutely. And actually, I've had conversations with the MSLs, the medical science officers of the people who produce cabotegravir, rilpivirine, and say, are you changing the product indication? Because we need to have that indication. They said, it has been brought up, but so far the FDA label it's for undetectable people, but it has been done for detectable people. And yes, people have been successful at suppressing people who have been detectable. Anything else? The link registry does not load. Okay. We are gonna have to correct this.
Oh,
Oh, thank you. Kekoa has a message. Let's
yeah.
see.
He's just echoing all of your great work, the two of you, and the center itself. Like, I think it's just all the kudos here. If you scroll up, Doc, you'll see that there's a lot of
Oh,
folks that are saying great, mahalo. So I'm glad that folks are finding value in this. We had one question come in. How does the Delta 32 mutation affect the chances of getting HIV? And what does it mean for people who have this mutation? If you could go, yeah, if you could reiterate.
we'll go back to this slide. So can we say that what is that again? Sorry.
Yep.
Okay. So we did not go through the nitty-gritty of this, but there are two. So Delta 32 mutation will protect you from HIV that uses this receptor CCR5. Majority of HIV strains will use CCR5. Yeah. So sorry, what was the second part of the question? What does it mean?
What does it mean for, what are the chances, or like, how does it affect the chances of getting HIV? And what does it mean for people
Oh,
who already have this mutation? Yeah.
so people who have this mutation will not be infected with HIV. That is using CCR5. So that is the caveat there. I didn't go to the again. My other master's degree is tropical medicine, so I can go really geek out about this. But so HIV can use multiple receptors. There is what you call an X4 virus, which can actually which it doesn't require CCR5, but it can use CXCR4. So they're not absolutely immune to HIV. They're immune to the R5 virus, which is majority of the virus. But in the rare chance that they have sex with someone with HIV that has the ability to use other receptors, they can still be infected. So I know for a fact that some people who are have this mutation, they are still on PrEP because they're afraid to what if they encounter HIV that actually is the X4 variant. They could still get it. But again, for the most part and majority of the viruses are R5, and so that is hopefully that answers the question.
Yeah, I think that the folks whoever asked the question, please let us know in the chat if that was along the lines of an answer that you were searching for. I'm just scanning the chat one more time. I think kudos again, mahalo nui for this very interesting and very informative training. I'm checking the chat, the Q&A, and this is a question about registration. So yeah, folks, if
Right.
you, I know there are different avenues that how folks can have registered. One was through Zoom. I see one that was through accredited sponsors website, and then we also have the QR code here. Please help with the QR code. I feel like that we want that information. We want to keep these trainings going. If you have chances to do it on there, that would be much appreciated for all the participants who have joined us, and we can have further future trainings together.
Thank you so
Oh,
much. It
yes.
was
And I did check the QR code and the URL, and with my materials, it still goes to the right place. So it may be that the QR code, because screen resolution or something, it may be sending you wrong. So if you're not getting to our registration page, then in the chat, I've put up several times, I've put up the URL. So thank you so much for those of you who registered. We really do appreciate it. And our regional office is going to look at these numbers and go, oh my gosh. So we are just really grateful to Hi-Fi for this opportunity. And we really seriously look forward to working with you further. Any of the rest of you out there who would want to work with us on
yeah,
bringing trainings to you, we are happy to do that. Let me put
visible.
my email address in here too. I am the program manager, and
So we do a lot of HIV talks, and so we can do an entire hour of just prep. How do you monitor people on prep? And then we have an entire talk on post exposure. We have an entire talk on HIV treatment. So just let us know what you want to hear, and this is our emails, Miss Amanda. Shivan, her hand, their hand is raised, and I'm not sure is there a question from Siobhan Fenton, or maybe it's just a
Yeah.
residual.
Okay. Yeah, I don't know.
Yeah,
Yeah, if you have the question, Siobhan, if you had it, please drop it in. I may have seen another one.
or
Christopher
and
has dropped in too.
Christopher.
Yeah,
Yeah,
we've got some time. We got 10 or so more minutes left. And so if folks have any more questions that are kind of, oh, lowered hand. That was good. Awesome. Well, thank you for engaging, in the in the conversation. Yes, we will have the slide deck. We'll send that to you folks after this training. And for some of the folks that are asking for the survey, that will also be in the Mahalo email. And for folks who want to earn their CEs, that's how I'm tracking for who gets CEs at the end. So yes, survey. I know it's a lot of all information, but it'll all be synthesized for you folks in a Mahalo email, along with the recording link for today's webinar, shortly after this training has been concluded. So I'm just gonna check a little bit
all
more.
right. I think, yeah.
Uh,
Thank you so much.
yeah, so
Okay.
anybody else? I mean, Doc, if you have any we got 10 more minutes, but like if you have any lasting thoughts that you want the
Uh,
participants to walk away with, yeah, like a minute or two you want to spit on, then I can close us up. But yeah,
um,
take the floor. I mean, you've already spoken, but if you have
yeah. Again,
anything
I
else.
mean, we are here. We are grateful for all our collaborators, or each people from HRC, Waikiki Health, Kumuka, Himawi AIDS Foundation, everyone within the state. We work closely with them, and we cannot do what we do without the support of the community, because as physicians, you prescribe the medications, but to actually get the patient to take their medications, their mental health support, Gregory House for housing support, it's a lot of the good news of HIV will not work if not for the entire team, and people, even if the medications are really potent, if the patient is having social issues, depression, or housing crises, those things have to be addressed, because otherwise they wouldn't be have the ability to take their meds, right? So we are very, very grateful for our community partners as well. So thank you so much.
Yeah. Amanda, do you have any final thoughts too? Appreciate you jumping on and helping
Um,
team this.
yeah, I would say one of the things we're trying to develop further is more connections with the social determinants of health type issues and the HIV health disparities. So if there are those of you who have information or would want to talk story with me
Mhm.
and or Dr. Louis about that, we would very much welcome that talk. I know we have had some people from Gregory House on this call, on this Zoom, as well as some of the AIDS services organizations, and we are just looking for a chance to get together with them and talk. And I just saw a last minute question. Do we know the percentages of people who choose to take the injection rather than the pill?
I really don't have a lot of numbers. I would say that it's still less than 10% of our population. Majority of people still are on the pill because it's one pill once a day, right? So before they go to bed, they take it. As opposed to an injection where, for example, me, I don't like needles. So even getting my blood drawn, I don't like getting my blood drawn. So I can imagine people were okay with having buttock injection every 2 months left and right, you know. So but it's great. Like for example, there are now nursing services where people, you could contract with some with the pharmacies, and the pharmacy will go to the patient's home and provide injection. But to answer your question, from our clinic here at the University of Hawaii Clinics, we have over 500 patients with HIV. I would say that less than 10%, or I could count in our fingers the number who are on the injectable. Yeah, just because of logistics or being needle averse, you know, like some of those.
Oh, and they said thank you. Yeah, thank you for that response. Thank you.
There's a Q&A tab that says, "Is there another way to register for the AHEC?" I couldn't do it with the symbol on the screen.
Oh,
Or was that the one
Pacific
addressed?
AETC. AHEC is in my office too, so
Pacific AETC. I don't know
uh
why, Miss Amanda. You know, I'm gonna have to check it myself.
yeah, no, I think sometimes you can't do it off of the computer screen. So I will put the URL code up again.
Maybe we
And
could ask for the Mahalo email. Do you think we could add that link eventually, just so
great.
people could be reminded
We
to? Is that
appreciate
okay?
that.
Yeah, I'll make sure to
Thank
include
you,
that. As
Melda.
well as I want to thank Brenda for this resource that they submitted and they dropped in the chat for help folks that
Oh,
are needle adverse. So I'll make sure
Oh,
to
is
share
that
that
right?
too. Yeah, she
Oh,
said like,
thank
there's like
you.
a healthcare vibrating ice pack. I never knew such a thing exists. So thank you for that link,
We
and I'll make
learn a lot, and I have to look into the donor, the organ donor thing as well, because that's not something that doesn't come up every day. But yeah, very, very, very good question. All right. Thank you so much.
Awesome.
Okay.
Thank you, everybody. Well, that is a
Okay.
wrap. I want to say happy Aloha Friday to everyone that's jumped on, and everyone who's joined, and to our trainers for this wonderful experience and this informative webinar. As a reminder, folks, yeah, we'll be sending the Mahalo email that will have all the instructions and folks how to make sure we register for and support a data collection for our partners over here, and as well as how folks can obtain their CEs through that evaluation survey. Thank you again, and everybody have a great rest of your day and have a great rest of your weekend. So, ahuiho, and thank you so much.
Okay. Bye bye.